Good afternoon, everybody. It looks like we are slowly getting people to join today, so we'll start in just a few minutes. If you are a committee member on the phone currently or on the meeting, please add your name to the chat so we can capture attendance. And if you're a committee member on the phone, please unmute and let us know that you are here. Thank you.
Hi, everybody. Welcome. We'll get started in just a minute. As a reminder, if you are a member of the advisory committee, please put your name in the chat. Thanks. Well, welcome, everybody. Let's give folks just one more minute. If you are a Medicaid Advisory Committee member, please put your name in the chat so we can just keep track of who's here. Sharon, do you know, I see Michael, Stephanie, Jennifer, Mary, and Brian are all here. Are there other members as well?
Yeah, so we're showing about 7 committee members, so we're a bit short for a quorum.
Okay.
If there are any members on the phone, please unmute and let us know that you are here as well.
Okay.
So Jesse, I can let you know when we have a quorum, but right now we do not.
Okay. Well, in the interest of time, we can just hold off on the approval of minutes, but in the interest of time, let's go ahead and get started. It's August, so people might be in various places and maybe on vacation, so we might have a slower turnout today. But welcome, everybody. Welcome to the August Medical Care Advisory Committee, the MAC. I hope everybody is doing well and staying safe. I would like to just make a quick announcement before we dive into the meeting, is that in accordance with the Open and Public Meetings Act, I've determined that we will be holding these meetings online until further notice. So if you have any questions or concerns about that, please follow up with me. And with that, let's get started. So we're going to hold off on approving the minutes until we have a quorum. But in the meantime, let's skip to agenda item number 2 with committee member updates. We will have a quick update on the communications committee and the notices committee. But first, for members that are on the line or members of the public, are there any updates, concerns? This is just the standing moment in our meeting for people to share things that are happening, any updates, events, I suppose, if there's anything or concerns, questions. It's just really an open forum for members to share their thoughts, and also because you are the experts in this area, to flag any concerns or positive things. Anything? All right. Well, if you have any updates, questions, anything to share, you can always put it in the chat too. Great.
And so, Jesse, we have just now reached our quorum, so you can go forward with the minutes.
Okay, great. Terrific. Well, I hope everybody's had some time to look through the minutes. Can I get a motion to approve them?
And we, just as a reminder, we do have two. We have June and July.
Oh, thanks, Sharon. I think we could just do in one fell swoop, right? In terms of approval. All right, can I get a motion to approve the June minutes and also the July minutes? That's right. Yeah, you didn't have the June minutes last meeting. You can also put your approval in the chat.
Jesse, this is Bill, and I make a motion to approve both June and July minutes.
Thank you, Bill. Unless anybody has any corrections to June or July, can I get somebody to second that motion?
I will second the motion, even though I wasn't here for the June meeting.
But the minutes looked fantastic. So.
Yes, thank you.
Thank you, Michael. All right, thanks everybody. And with that, last call. I just want to make sure that if anybody had any updates, concerns, questions, this is a good time to bring them up. All right, last call. All right. Let's move on to committee member updates for the notices or communications committee. Jeff and Maurice. Is Maurice here or is Maurice out of town?
He's not back yet. He's expected, I believe, next week, end of next week. So just me today, but we do have Melissa Presley pinch hitting today. So Melissa, we'll call on you if we need some help.
Great, thanks, Melissa.
As far as the notice committee, we did get together with a small group. Unfortunately, the meeting appointment was not sent out in a very effective way, so we apologize for that. We've hopefully fixed that for future meetings and plan to do so again, plan to meet again next month. So we did meet one time and we're able to, so we had Workforce Services, myself from the Department of Health and a few others. Jesse Mandel was able to attend as well. And we talked through one of the notices that we're sending out and just talked about that process a little bit. What we are hoping to do as we get a little bit better at this would be that when a notice is redone or a new notice is created, that we'll try to also shop that notice, if you will, and try to get some feedback out from the community just to make sure that we're saying things that make sense. In our world of eligibility and probably our world of Medicaid, we use all sorts of acronyms and all sorts of fun things that may not make sense in the real world. And we try to be aware of those things, of course, but sometimes we miss. This will give, we hope, as we move forward, more chance for the community to give some impact or some input into what they say and how we say what we are trying to get across. So that's the start of this group, and we're hoping again to meet again in a couple weeks. We'll continue to meet going forward for a little bit to see what notices we want to tackle first, where we think that's appropriate, and again try to get this more regular pattern set up where if we do create a notice or make a change to notice, that we're quickly getting those notices out to someone else to take a look and then get that feedback and then move forward. So we're excited to see some positive changes in that area. Any questions?
Jeff, do you want to say anything about the spreadsheet?
Oh, sure. Yes. Unfortunately, in the state of Utah right now, in our current environment, we're able to do a lot through Google documentation, et cetera. Unfortunately, it is not as easy as we had hoped to share a spreadsheet back and forth with everybody. What we are trying to do is to actually show, one of the early comments on this particular item was that, if you get feedback from us, how do we know you took it? And we want to make sure that we're very clear that if we do take the feedback, that we can show you what we did and when we did it. So we have created a spreadsheet on our side. We had intended to share that across the world, but I guess our firewalls are strong and doing what they're supposed to do, and I guess protecting us from evil or whatever it is. Anyways, we at this point will probably have to take some email and do email communication. We can certainly send the spreadsheet itself back and forth through email, and that might be an approach for the interim while we try to find a better way to share this information back and forth. Again, the idea is if a notice is found that we want to take a look at, we would log that notice. You would see what changes were being made, and then when those changes were made to that notice and when it was updated. That's the intent. Again, the sharing has been a little bit tricky, but we'll figure that out. We may even tap Sharon and some others that may not have better ideas of how to do this.
Thanks, Jeff. And I actually sent you a Google Doc. Maybe we can do some sort of wonky, I create it and then you share it out, but we'll play around that. But it's a great way for, I think, we created something similar. Some members might remember, like a little Google Doc to log some issues. And I think this is a way to take it to the next level and to really dive into specific notices. And then when we meet in September, we can address those notices. So I think even though it was, even though the meeting was a little hasty last time, I think we did make some good progress just looking at that one notice. And I think we'll continue to do that. And it was, a learning curve for me too, to realize what is some of the constraints you all are under as you're trying to make these updates to the notices.
And Jesse,
go ahead.
I'm sorry, Jesse and Jeff, I think, why don't you touch base with Nicole? Because I do believe there is a way that DTS can set up a way to share a Google Doc, but you have to specifically request it with entities outside of the state.
We'll do that.
Okay.
That's great. And I think too, we've got Sarah, we've got some members that have expressed interest in this notices committee. But if you are interested, please just let me know or let Sharon know too, so we can make sure that you are looped in as well. Gina, you're on our radar. You've been getting those emails as well. Sarah, do you want to go ahead?
Yeah, thanks, Jesse. I saw Maris on the agenda, but I think Melissa is here from DWS just before we moved ahead. From what we're seeing at Take Care Utah, just working with clients in the last few months, it seems like processing from the imaging department is pretty backed up by a few weeks. So we're just a bit concerned that how things are being marked as verified or received for the timeline for, public applicants for Medicaid. So if someone is sending in a verification, is it being accepted at the time that folks are sending that in, or is it by the time that imaging is processing those? Are there any clarifications being offered to folks that are applying? Any leeway with delays, or just an update about the delays that we're seeing on our side?
Sure, I can answer that. I think you got the email from Cami Galt, our imaging manager, yesterday. So there are some delays with imaging. We've had some problems with our imaging system. So that while that does delay getting things imaged into a case, when it does get imaged, it will be with the date that the customer actually turned that in. So for a worker, they would only see the date of when it's turned in, not necessarily the date it was imaged to the case. So it could impact a little bit to a customer delay as far as seeing an application, things like that. But the date, a customer wouldn't be punished or penalized for with those delays. So it'll still go off of the processing timeframe of when it's turned in, not necessarily when it's imaged, if that makes sense.
Yeah, definitely. And just a follow up there, is there a specific time that folks need to be submitting things, or can it be any time on the date that's listed on the due date of those verifications?
I believe it says by 5 o'clock on the due date. So I think that's what it is standard across the board with most of the due dates on there. But really, if they turn it in, that's mostly kind of old school for when we had, when people would turn them into like employment centers and things like that, because that's when they close. But if they turn them in by 11:59 that day, they still get date stamped with that particular day.
Okay. And are there still the drop-off boxes available at most of the DWS offices?
Yep.
Okay. So is there any, I mean, how are those verifications and applications, or how are those listed by receipt date? If there's not, right, if there's not a received fax or a received email timestamp.
So anything that's turned into an office, if it's after 5 o'clock, then it is the next business day. But if it's electronically turned in, then we can record the time that they turn in. It is the date, as long as it's before 11:59.
Okay. Thank you.
You bet.
Okay. Thanks, Sarah, for asking a question. Thanks, Melissa, for your help. All right. Great. Well, that's probably a good segue to Jeff with the enrollment and expansion discussion.
Sure, we'll keep this fairly brief today, unless you have questions. Looking at the numbers, you'll see that we're starting a whole new fiscal year, so it looks like the numbers have shifted a little bit there, but the history is retained. You'll see that you have several years of history there. If we can move down to the graph just a little bit there for Sharon, I appreciate that. This is the number of Medicaid CHIP, and I love that we've kept PCN up there. We'll probably slowly start to trickle that off. You can see it's still that bottom line, but eventually that name will come off the title. The overall trend, though, is that we are increasing in enrollment, not a surprise, as we retain the eligibility in Medicaid. We still do take new applications, and so we have an increase overall in the number, and that's expected to continue throughout the public health emergency. And then if you'll, well, I don't know if you can focus in a little bit more. I know it's a little hard to see the numbers. Can you zoom in just a touch, Sharon, by chance? If you can't, that's, okay, there we go. So with the July numbers there, you can see that we have had a slight decrease in pregnant women of 100 pregnant women. That follows the trend over the past several months and really is the change we made. Well, the guidance came out in November last year, but the change was made in January, February this year to start moving people from one bucket of Medicaid, if you will, to another bucket. So this allowed people, instead of being a pregnant woman for 18 months here, we are able to now correctly put you into that program at the right time and then move you on to a different program. So you'll see that the pregnant woman program itself looks like it's slightly declining. And that should explain the slight decrease you've seen for the past, it looks like 5 months there. We also had a decrease at the time of this report for CHIP for 336 additional children. CHIP has returned to normal eligibility and is running how it did in the past. What that means is that we are doing reviews, and if the review is not completed, the case can close now, and that does impact that program obviously more than the others, which are increasing simply because no one is leaving the program. We have, matter of fact, just recently got off another call with CMS talking about what we're going to do at the end of the unwinding process for Medicaid. And one of the things I hope we will all not see is what we have seen with the CHIP program, unfortunately, as we turn the rules back on and we're not able to review all the cases in the same way. In the past, I've tried to encourage this group to encourage people to complete the reviews. I'm going to change my stance just a slight bit. We'd really like people, if you could, to encourage them to report their address changes. We believe that we have a problem of address changes in the world where we're not keeping up to date very well with people shifting around. People during COVID have continued to move, and our population is a transient population by nature. And so that reporting, we know we're not number one. Obviously, you got to get the cable set up and some other things set up in the house. We understand that. But as that occurs, we do want to make sure that the Medicaid address gets updated. It is going to be very important because that's where we'll send the review when the time comes. And if that address isn't up to date, we're not able to catch up with the person, and unfortunately could mean ending the eligibility, even though the person is truly eligible if we were to know where they were. So please encourage people not only to complete the reviews, but also to update the address. And I think you'll see the state slowly move forward to try and do a little bit better job with that aspect of this in advance of the closing of the public health emergency, which again is not closing that we know of anytime soon. We ask the same questions you ask. We have not heard a date for this. A lot of people are using the end of the year as the end of the PHE just for illustration purposes, but we do not know when the public health emergency will end, and we're watching the same COVID numbers you are. So with that said, we can quickly scroll down and look at the other two graphs, Sharon. Sorry, I probably should stay on one topic for a moment longer. You'll see the adults here is really what is driving and this is no surprise to any of us, the adult population continues to really drive the curve of new enrollees. And it's been impressive to see that grow over time. You see the initial bump from the first expansion. And of course, as we went to full expansion, you see that steady line really since that time. That was back in April of 2020, or sorry, just slightly before that. Anyways, the bottom line shows the children, which we do still cover a large number of children, and the graph looks almost identical to the trend of Medicaid because there are so many children enrolled. And I guess at this point, we'll take any questions you have.
Well, Jeff, so can you just say, and I see Sarah has a question in the chat, so maybe real fast. Premiums are still not being enforced. Is that right?
Correct. And thanks for pointing that out, Sarah. It's actually one of the strange anomalies that we didn't expect. Those premiums, when we charge them every quarter, at least we were getting an updated address once a quarter, and that's something that's missing today. So that is correct. We are not charging CHIP premiums and have no intention of doing so until the end of the public health emergency.
I guess my follow-up question on the CHIP enrollment. So where are we at? Because looking at the numbers, do you have a sense for how many people have come back on? It doesn't look great because of what we might have hoped.
It doesn't, and I know the numbers lag a little bit here. Over time, we're finding that there are some returning to us, and we expect that's the case. And we talked about this a little bit before, but before you could at least probably trust that the notice you got that said you weren't eligible meant exactly that. During the past 18 months, I think our messaging has been a little confusing, and therefore, rather than getting the notice that they're closed, even though it's real, they may not understand that that's a real event until they go to seek services. And unfortunately, that means that they're going to seek services, find out they're not open, and then return to apply. So I do expect that we'll see more of those over time as the need comes up. One of the big needs, obviously, right now is school is about to begin. Some of those school visits that occur, those medical visits that occur prior to school starting, I think will trigger some of this as well. So we are following those numbers and want to see what happens over the next little bit here. But yes, we're following that just like you said. It's lower than
so
we
Jeff, I think when we first when we switched CHIP back on to be the way it should normally operate, I think there were, well, I thought we identified maybe 1,000, maybe 2,000 that had recycled, come back on because they had identified, they realized that they needed to complete a review and went through that process. But we also had the HPRs do some calling out to families whose CHIP cases were closed. And a fair number of them indicated that they were fine, that they had, looked for or enrolled in their employer-sponsored insurance, or they just really didn't have any intentions of coming back to CHIP. So that's kind of interesting to us as well. But I agree with what Jeff has said. Some people won't really realize that they'll need CHIP until they have a need for a medical service. And even when we charge premiums, that was not unusual too, right? I mean, a lot of families would allow their cases to close, choosing not to pay the premium because they didn't have a medical need and would come back in when they did have one. So we'll have to see how many. And of course, like we've said all along, one of the major places that CHIP gets new kids from is from Medicaid. And so once the MOE is ended, and kids in higher incomes will just naturally end up going into the CHIP program. So we'll have to see how much of that occurs too.
Do we have a sense, to your point, Emma, how many of those? But we don't know.
We don't, because we don't know what their real income is, right? I mean, these are going to be, families who are between the 138 and 200% who would be reviewed by DWS and determined to be eligible for CHIP, and we really don't have an idea at this point.
Oh, and I meant, sorry, do we know how many of the people, of the families or the children that have had their cases closed over the last few months? We don't know how many are have another source of insurance or are no longer income eligible.
No, not for sure. I mean, this was just based on as the HPRs were calling out, we asked them to keep like some rough numbers in terms of, and that's always a challenge too, because a lot of times our members don't keep their phone numbers current either, or they're not available during the day, especially if they're CHIP income level. They may not be available during the day to take the call. But the ones that they did get a hold of, a fair number of them indicated that they didn't have the need for the program anymore, largely because they found employment and had some access to some other form of insurance, or they were just choosing not to continue the program. And quite a few they just couldn't get a hold of.
Great, thank you for that. Are there any other questions about this report? All right, thanks, Jeff.
Thank you.
All right, well, oh, Emma, were you going to say something?
Oh, no.
Okay, great. Next, we have Brian, who's going to give an update on Medicaid members' vaccination rates and some of the information he's been looking into.
Great. Thank you. I will take over presenting real quick. All right. Thank you for having me. So at previous meetings, well, sorry, to begin with, I'm Brian Roach with Medicaid. At previous meetings, we've given some high-level percentage differences between what we've observed with our Medicaid members getting their COVID-19 vaccinations compared to the statewide rate. This report aims to do a little bit more specificity about differences by age groups and geographic differences. Just some ground rules on how I'm going to speak just in shorthand. When I say Medicaid, I'm largely talking about Medicaid and CHIP. The vaccine eligible population, as many of you already know, is ages 12 and above. And I'm largely showing the first dose rate. So you can measure those that have received at least one dose and those that have received both doses of the mRNA or one dose of Johnson & Johnson. But just for simplicity, I'm talking about the people that have received at least one dose. So first, a few more disclaimers about how this data is calculated. So statewide vaccination rates are published on the state's COVID-19 dashboard. That's here. It's publicly accessible. It's very detailed. I encourage everyone to review them. For the most part, these measurements, you take the number of people vaccinated and divide by the most recent census estimate of a population. So there are estimates by local health district here. There are estimates by age groups here, and then small area estimates down here. And that's where I'll start diving into next. But these are based on census numbers, most recent census numbers. That is the denominator for all of the rates that are displayed on these dashboards, or this one dashboard. So with Medicaid, our population is dynamic. We have thousands of vaccine eligible members that newly enroll in Medicaid every month. So it's a process to update our numbers, find out among the people that newly enroll in Medicaid, are they vaccinated? I am securely sharing that data with USIS in order to get their vaccination status so that I can update our vaccination rates in order to compare to the state. In addition to that, we have children that turn age 12. We have about 1,000 of them every month that become vaccine eligible. And those 1,000 members get added to our denominator. And until they get vaccinated, it will slightly turn the vaccination rate down until they get vaccinated, and then we can start increasing the vaccination rate again. So it's a constantly changing rate for us compared to the statewide denominator is fairly stable. So I do see a raised hand. Is there a quick question before I continue to the rates?
Sorry, that was by accident.
Oh, okay. Sounds good. So scrolling down, the Utah small areas have been defined by an office within Department of Health. They are a grouping of zip codes that share common authorities, population characteristics. They're about 30 to 50,000 people per small area, and there's 99 within the state. So when I scroll down here, you will see each small area begins with a prefix, and those prefixes correspond to the local health departments up here. So one being Bear River and so on. The second column in this entire table is Utahns in that small area, age 12 plus, and their first dose vaccination rate. The third column here is Medicaid members, Medicaid and CHIP, age 12 plus, and their first dose percentage. And then finally showing the difference between the two. So there is some obvious difference here. There's a whole lot of red on this report. I think a certain amount of the disparity is noticeable even at the statewide level. So again, jumping back to the statewide dashboard, there is some apparent socioeconomic differences in who is getting vaccinated. There's urban and rural differences. That is the groundwork before we even go into Medicaid. And some of that plays through in these vaccination rate differences. So to begin with, like the largest difference comes in Summit County area. They have a phenomenal vaccination rate among all individuals residing there, almost 97% of their vaccine eligible population. But that also is evident with almost a 50% difference between the Medicaid members living there, 50% fewer of them, or a 50% difference in vaccination rate. Our worst vaccination rate comes in rural areas of Washington County. So exempting St. George and Washington City, the other areas of Washington County, we have a very poor vaccine uptake, only around 15% of Medicaid members. And so that is definitely a struggle. But I won't go through this, each and every number here. This report is available for you, and maybe there are specific questions. I'll jump down to the vaccination rate by age group. There are gaps on each and every age group, but the largest seems to be the 40 to 49-year-olds. We are seeing highest vaccination rates among those most vulnerable, so that is good in a sense. But we have a large number of children, pregnant women, expansion adults that may not view themselves as vulnerable, that are generally getting much less vaccination rates than the population as a whole. And then finally, I did not put these numbers directly compared to the statewide numbers among race, ethnicity, because they are differently calculated. With our Medicaid members, I am just assigning this based on the DWS data we get, which is primary race identified or ethnicity. On the statewide dashboard, there is some duplication because individuals may may identify multiple races, multiracial, multi-ethnic, and those are reflected, but they're also duplicated as a result. So neither method is right or wrong. They're both valid, and people may choose to compare the numbers on the dashboard to the numbers I submitted. Because of the differences in calculation, I did not put them side by side. So I am welcome. I welcome any questions. I think, Jesse, you may have also intended to get some broader committee member input, but I'll open it up for questions.
Brian, I'm sorry, can you just repeat that last bit? You broke up on my end. You said you might have questions from...
Yeah, I wasn't quite sure if you were going to get committee members to give some input on vaccination efforts, but I think that I'll turn the time over to questions or you.
Okay. I just want to say this is really helpful. I mean, thank you for doing this. This is really great to see. So thank you for all the work and for others that have worked on this, but thank you so much, Brian, for your analysis on this. So let's start with committee questions before we turn to kind of the what to do, the committee efforts. Are there questions from committees or from, just to reiterate, if there's any members of the public listening, you can always ask questions too. You can unmute yourself or put it in the chat. So let's just open up to questions.
Thanks for this, Brian. I appreciate this. And you mentioned, the perceived risk, which I think is a part of maybe some folks' calculation on whether they should be vaccinated or not. But we also know that there's a lot of data showing that, Medicaid members exclusively, or even, when compared to Medicare, Medicaid, and Medicare, like the dual enrollee population group, they're higher severity of disease, hospitalization, and death rates compared to like their peers. Seeing these disparities, I guess I just want to add to that this is, concerning for a lot of reasons, but it's concerning because Medicaid members tend to have more health conditions, disabilities, the proximity and to poverty and how that is a social determinant of our health. And so it is the need to improve the rates of vaccinations in this population group is just so, critical to long-term health outcomes, because we just know that as COVID spreads and these folks don't have that protection of the vaccine, then they're much more likely to end up in incredibly difficult situations and more instability in their lives. And so thank you for doing this, because I think it's really important for us to see. One question that I did have, and if you don't know this, I know I can look at it too, but the Health Improvement Index is also grouped by like the small area. So I know at one point the areas with the areas that were like very high, I think is like how they're calculated. And I think very high is like when they have a lot of health disparities. I know early on those areas had really low vaccination rates, like compared to like the areas with like low health disparity. I don't know how they kind of interpret that, but I know it's kind of on a low to very high scale. Do you know if that's been, I'm assuming that has that stayed, or have they found that some of the areas with significant health disparities do they stand out as like outliers in terms of like being able to close that gap at all? I'm just wondering like if there's things we can learn from areas that we would think maybe would have like a greater disparity or less vaccination rates, if we can learn anything to then, you know, maybe try to like scale that out or try that in other areas. I don't know if that question made sense. Sorry, I'm kind of spacey.
I think I understand. So essentially, whether any efforts to close the gap, is particularly in COVID vaccination outreach, has made a difference in overcoming those disparities?
Yeah, I mean, like if you look at, I mean, like I think Glendale is one of the high health disparities on like that health index. I mean, if they have, yeah, I mean, if there's anything that we can learn from areas where we maybe would have expected lower vaccination rates, so they're exceeding expectations based off of like what we just know about the health disparities in general in that area. Like if there's anything that's working that we can then maybe push out to other areas. Yeah, I guess that's what I'm just trying to understand.
And I don't think we've done that analysis. And it might be, you know, Jesse just pointed out the report from the Office of Health Disparities. I'm wondering if maybe if this committee is interested, maybe we could ask Dulce or others to come and share some of that information with the MAC. Because Brian, I don't believe that you've had that discussion with Dulce, right?
That's correct.
No? Okay. But something definitely we should look at. I think it would be an interesting conversation. And maybe we could learn some things. Stephanie, basically, you know, based on what you're saying, I would just observe or make one observation. I was on a call recently with the other states, and this disparity in vaccinations for Medicaid members is not unique to Utah. And all the states are struggling with it and trying to figure out why this is occurring and what to do to address it. So I think if anybody has some ideas, some thoughts, you know, we've tried calling out to Medicaid members. I think as a result of that effort, I think we reported at one point a couple thousand people did get vaccinated as a result of that personal contact. We're looking at trying to send stuffers out in some of the mailings that we do, and we're working with the immunization program in our department to basically put that together. But again, the challenge is, not to go back to one of our previous discussions, but if people don't keep their addresses current, then they don't get that information either. So, I mean, we're trying a number of different ways. I mean, obviously, when the personal contact seems to be the biggest issue, and probably personal contact directly in those communities always seems to be something that tends to be helpful. But yeah, how we do that and who does that and how we essentially pay for that too is a challenge. And Courtney, you've got your hand up.
Yeah, I was just wondering if this report has been sent anywhere else, like to any of the other state agencies or to the governor's office.
No, I mean, this was just prepared based on a request for us to look deeper into the data and provide. I think, Stephanie, what state was it, or Brian, who had a good report? California. Yeah, and Brian was trying to replicate some of that same kind of reporting and data to see if that was something that would be helpful to this group and to others. So we haven't really circulated it anywhere except for this group.
So so after California released that report last week, they this was sent to me, so I'm looking for it, but they also then just appropriated some funding for, I think, and maybe this came up on that call, Emma, that you were talking about, but they appropriated some funding for, I think they're telling the health plans, oh yeah, they're saying $350 million of incentive payments for health plans to boost COVID vaccination amongst Medi-Cal members. And so, I mean, it seemed like the report came out and then it pushed them to maybe try to push some policy changes. But I've also seen some efforts of like, you know, just a lot more kind of block by block and door to door, you know, campaigning or canvassing, sorry, and, you know, going into areas where there's subsidized housing, public housing, and things like that. And then I know that, I mean, I've seen a few examples from states, and where I'm from southern Arkansas, where it's really been rough there, and that those efforts, you know, they are seeing, from what I hear from people I know there, those efforts are helping. They've increased vaccination rates in some areas that, you know, has some really big gaps and are really impoverished communities. So I mean, it seems like some of the more like really trying to get into the community and talk to people, and then also just having primary care doctors call their patients, which I don't know if there's any way, I don't know how that would work in terms of like, you know, making sure that they can be paid for those services. But I mean, from what I've heard from some rural doctors I know down in Arkansas, that's been, you know, they've been able to get quite a few people. I mean, you know, for these small communities, quite a few people have been able to get vaccinated because of those efforts. So those are things that I've heard about. And then Baltimore is doing delivery, so vaccine delivery. So you call and they'll bring the vaccine to where you live and just do it at your house. And you know, a lot of us on Medicaid, for whether it's, you know, our disability or our income, like we can't drive. And so I think maybe, you know, some of those delivery efforts could be something to look into. Those are the things that I've heard as I've looked into this, and I've been trying to find things that are working, and that's what I've seen so far.
Yeah. So just so you know, and I know Jesse put something in the chat as well. I don't know that the plans, I don't know, I see a few people who are on the call, but you know, we've been meeting with our ACOs for a while, and so they have been trying different things as well. Some of the things very similar to what you've indicated, that some of them that are part of, you know, whole systems have been reaching out to their to their clinics and their primary care doctors, and, you know, sharing information with them and trying to get them to also emphasize the vaccine. We have had, I think, one or two of the plans actually ask us if it's acceptable under Medicaid regulations for them to provide incentives to get vaccines. And of course it is. It's, you know, they can certainly do that. We told them they could do that. We do have at the department, actually, and I believe this is still in place because we shared this information with our plans as well, where you can call in, and for instance, if someone is unable to, like they're, you know, maybe a shut-in, or they don't have any way of getting out, you can actually call a number, and we can get that information and share it with this group. In fact, we'll give it to Sharon to share with everyone. And they will, the department has agreements with, like, you know, community nursing services and some others where they will go out and provide the vaccine. But I don't know how much of that activity has been going on. We know that it's been used. We know the plans have used that a few times. The department has used that when they've just recognized that maybe a certain area or certain group or needed to have someone to come out to actually provide vaccines. So I think in some ways a lot of these things are being tried. I think we just don't know yet how successful they are. And maybe they could be done in a broader way or in a bigger way.
Thanks, Emma. I mean, and I would just echo like to what you just said, that some things, it seems like incentives should be happening across the board right now to the, that all, we would hope that all health plans could be doing incentives. And so thank you for clarifying that it's within the regulations, because it seems like that is a clear way to lower costs when people are not getting COVID. So I hope that's, something that can be amplified as our efforts like mobile clinics and after-hour clinics and things like that. So, the more that we can help, sort of the larger members on the, people on this call and advocates and community members to get the word out is something I hope we can all do to help get this message out. So Brian, thank you again for this. This is really great.
Yeah, you're welcome.
Are there any other questions before you zoom away?
Can the health plans chime in? I'm just curious who is offering incentives and how they're messaging that, because it does seem like, yeah, like maybe just trying to get some messaging out better. I mean, I haven't heard anyone that I know even be contacted. I don't know. I'm just curious if there's any more details about that, because I guess that doesn't match what I'm hearing, to be honest, from people that I know that I check in with.
Actually, Stephanie, I should say I heard the same thing, that I mean, anecdotally, but not getting a Medicaid member not getting calls from health plans, and they were surprised too. I think just that, how are we getting this information? And to your point, I know numbers change, addresses change, but how is that information coming through trusted partners like health plans?
And the health plans generally get that contact information from us that comes from eligibility. So if, again, I get back to if folks aren't keeping their information current, I mean, sometimes health plans will get updated information, but the majority of it essentially comes from the information that the members provide. So I don't know, I hate to put our plans on the spot, but is anyone who might be on this call who may want to just speak to what you're doing?
Hey, Emma, Jesse, this is Todd Wood with Select Health. I can speak just, a little bit to that. I mean, Emma, you laid it out pretty well, what we've been talking about. A lot of what we've been trying to do has been in partnership with Intermountain, trying to get the word out there through the delivery system. But we did some early on some kind of larger blasts, calling and even emails and text through, at least Intermountain did, through some of their lists. After a little while, what they were hearing back was dissatisfaction on the member side of stop asking me, and they didn't want to be bugged about it, quite frankly, if they weren't interested in the vaccine. And so that kind of slowed down, and they started to take a more targeted approach, as you've stated. With each, we would work with them to provide lists to clinics of their patients who were still unvaccinated, and then those clinics would do outreach or speak with patients as they were coming in. In terms of incentive, Select Health is looking at that, and we haven't yet implemented anything yet, so you wouldn't have heard anything from anywhere else, and anything publicly at this point. But we are looking at it on how the feasibility and how we would be able to do it, and what steps would need to be taken to do that. So we hope to have something on that soon. Especially with the rising caseloads, as we see it. Intermountain is especially cognizant of the impact as the cases increase, and so they've asked us to look into new ways to try to get the word out there, and which we're doing. We're happy for any sort of thoughts and suggestions coming from the community, though, as well.
Todd, thank you. Thanks so much. Leah, I see that you your hand is raised too. Are you able to share anything from the University of Utah Health Plans?
Yeah, we're kind of in the same position as Todd was saying. I was just speaking with our marketing team and our outreach team, and we've had a lot of encouragement being given by our care managers when they speak with any of our customers and our customer service team. But our outreach team has sent out emails and postcards. We've expanded the language reach, and we're sending to Arabic in addition to English and Spanish. In terms of those postcards, we've not implemented an incentive yet, but that is something, you know, that we can look into. So.
And I'm sorry if this puts y'all on the spot. What are you waiting for? Like, is it the cost? Is it like, I'm not putting blame out. I just feel like we all agree that this is important. So like, what needs to happen to get the incentives out, or like, you know, beyond like the mailers, like to get primary care doctors to be able to, or nurses or Medicaid members who have been vaccinated to go door to door too, like within their own, you know, area, like recruiting them to be ambassadors. Like what needs to happen? Is it a lack of money? Because I hear there's just tons of money that's not being spent. So I'm just like trying to understand where, like, what's the holdup? And I don't mean to be rude or blamey about that. I'm just trying to be honest about like what else do we need to do? Is it money, grants, funding, like people? I don't know.
I don't know if any of the plans want to respond to that. I'm assuming and I'm just assuming part of it might be just logistics of, you know, how to get that done. I mean, but that's something I think we can certainly have more discussion in our meeting with the plans to try to work through some of those. And I don't know if the plans have any.
Yeah, I think unfortunately we just probably, I personally am not prepared for that question.
Right.
Not participated in those discussions in terms of, you know, why something hasn't been done yet, or what the plan of action is, and the timing for that specifically related to vaccines. And so that's something, it's definitely a question we can take back and, you know, discuss. I think, like Emma said, having discussions with the state in our plan meeting, I think would be a great next step for sure.
Yeah, and I think what we could do maybe is come back with maybe the our next agenda and maybe have some specific, you know, updates from the plans. And right now we're only talking ACOs, but you know, the prepaid mental health plans, the local mental health and substance abuse authorities also can play a significant role here. And I think some of them have also done some things to try to encourage vaccination, but that's also a point of contact for a lot of our members. And we really haven't engaged yet the dental plans. And although people don't go in and, you know, interact with their dentists as often necessarily, you know, we could get some more information from them too, to see if they're doing anything proactively, or if they could do something more proactively with their enrollees. And then to Todd's point, I mean, I do think sometimes people get to a point where they don't want to be contacted anymore. And you know, there's that fine line of, do we just continue to keep doing it or not? So, but we can certainly come back to the next meeting and just put that on the agenda and have the plans come in and basically give a more comprehensive overview of what they've been doing and what plans they have to do in the future.
Thank you. And I'm happy to help anyone with, I talk to poor people and Medicaid members all the time, and I am really open to doing anything because we can't give up on this, and I just feel so strongly about that. And I think it's imperative to like the goals of Medicaid and for health plans that are being paid to manage the care of these population groups. Like, we have to do more to get this disparity. Disparities are unjust and preventable, and these disparities in vaccination rates are unjust and preventable. And I strongly believe that. I know some people are going to like be mad about like being contacted, but I think there's a lot of people that it's the relationships that, you know, that of the people that they trust. And we just have to find a way to do this now, because it's relevant to other metrics that we look at too beyond COVID. I mean, the breast cancer screen, I mean, we've talked about this with other quality metrics. So I just think it's like, this is just an indicator of a bigger problem. And I think we need to I just think it's just so important. And I have a lot of opinions about why this population group does have disparities, and I wasn't surprised by it. So I just think if anyone wants, I'm happy to volunteer my services to do anything we can, because it's critical that everyone has the opportunity to good information and to trusted relationships with care, you know, healthcare providers that care about them and value them. And when you don't have that, then it just makes it harder. And that's, you know, it shouldn't be a death sentence for people. And so anyway, thank you so much for all of your work. And
Hey, Jesse.
I appreciate that.
Jesse, this is Brian. It's only taken me 1 hour to get myself off mute today. So I'm sorry, but yeah, and you know, this is Melina, and I know the other health plans have done similar things, but you know, we take the lists that we get for redetermination, and as we call out to try and get our members to go in and get their redetermination done so that they can stay on Medicaid and CHIP, we ask them about vaccines while we have them on the phone, and we guide them to the closest venue when they say that they want the vaccine or they haven't gotten it, but they're thinking about it. I mean, I know the other plans do this as well. We even have clinicians that actually go out and give and do administer the vaccines. I know Select Health's done that. I know Healthy U's done that. So the plans are doing a lot. And I think the only thing I'd say is until you actually get on the phone and call these individuals and talk with them about it, I think that's when you start getting a real good sense of either they've already got them done, or they don't want them, or they just don't have the energy and the time to go out and do it. There's a lot of varying reasons, and we've actually written down all of the reasons and put them in categories when we actually hear about them. So things are being done on a health plan level.
So thanks, Brian. I do think it would be helpful, though, if we had the plans give a more formal report, maybe next meeting, you know, because I know you do that with us, and I think that's helpful, but I think it would be helpful for the MAC and the public to hear, you know, the extent of, and maybe even some of the feedback that you are getting. So
sure.
We'll plan on that for next month.
Mm-hmm.
Thank you, Brian. I know we're at time, so I do just want to, you know, thank you for echo what Stephanie said. You know, thank you for this report, and thank you for the work you all are doing. And the report that I put from the Office of Health Disparities really does look at the access barriers, and I know that's what we're talking about. But I hope, you know, that's not a part that we should overlook, because it is a huge reason. And so I think maybe sometimes we can say, oh, well, it's easy, I think, to overwrite and say, oh, it's just hesitancy, or kind of dismiss that there's a lot of the barriers that are still there that people are facing that we can work together to overcome. So thank you for that, and look forward to hearing this on the agenda at September meeting. Thanks. With that, and actually a good segue as we think about school-based care as a good place for also looking at places for people to get vaccines. Matt is going to, oh, actually, sorry, Jennifer Lloyd, you have your hand raised, and then Matt will be up with the update on the schools-based skills program. Jennifer, do you have your hand raised? Jennifer Lloyd?
My apologies, not on purpose.
Okay. Thanks. All right, Matt Ahorn is going to give an update on the school-based skills development program.
Yeah, thank you very much for the opportunity to come share some of the things that are underway with the school-based program. If you could scroll down to the next section. Yeah. So basically, to give some context, we've been making some changes in the school-based program over the course of time. Last year, the initial phases of our shift, we made some changes, including removing some of the eligibility barriers to participate in the program. So before we had a limit in terms of the number of students that could participate based on the level of services needed on their IEP. We've removed that barrier. We also increased the age range to allow inclusive of 21-year-olds to participate as well, before it being capped out at 20. And then this is kind of moving into the second phase of some of the changes. And to go over the broad strokes of the changes effective July 1 this year, there are two main components with lots of moving parts associated with that. But one is moving from a fee-for-service reimbursement to a cost-based payment methodology. Historically, we paid out basically a fee-for-service, but it was based on a bundled daily rate. So every service being received for a student, whether it be speech-language pathology or physical therapy, all got kind of bundled into a daily rate that we paid out per student per day of attendance. Then nursing was billed out at a 15-minute rate. So this left us with some problems. One of the bigger ones is that it left us significantly out of step with CMS's current guidance on how they want reimbursement for the school-based programs across the country, which comes with it some liability that we needed to address and understand as well. But maybe the bigger concern is that the older process, the bundled daily rate, things like that, didn't necessarily fit all that closely with each of the respective districts or LEA's special education program and their cost structure. And so as a result, this process allowed for the possibility of leaving some money on the table. It was determined that the best way to approach that is to go with a cost-based payment model. The structure there is basically we look at what the cost is to render service based on the cost materials they submit. We go through time study processes to determine what proportion of the cost they submit is actually directly attributable to the rendering of the services that we're covering, right? So the idea is look at the cost. What is the cost it actually costs to render the service? And we will reimburse them that. In the previous methodologies, if they didn't submit claims and their cost was higher, then they didn't necessarily get that funding and they may be consequently under-reimbursed. With the cost-based payment methodology, we reimburse them up to the maximum that they could be reimbursed. That's the idea. Some of the benefits associated with that, again, it brings us more in line with CMS's most current recommendations in terms of how they like to see this done. It allows us to maximize that reimbursement, and I think that's what we're looking for. So, yeah, go ahead. Did somebody say
Sorry
something?
to interrupt you. I was just thinking before you continue, because I think these are important changes. Can you give like a very quick sort of high level what the school-based skills development program is for people that might not be familiar with it?
Sounds good. I wasn't entirely sure how much context to give, so I gave some historical.
No, I think that's great. Just a little, yeah.
Yeah. So the idea is that special education programs across the country are rendering services as part of their requirements pertaining to education-specific regulations. IDEA in particular, IDEA Part B, if you're looking at it, has direct application to this program. But those educational requirements indicate what they have to, the services they have to render. The special education system will be evaluating each student and setting up individualized education plans as needed to help provide services to allow students, the kids, to more effectively take advantage of the free and appropriate education. So if someone has a speech need that's not permitting them to fully take advantage of the free and appropriate education, the idea here is that the special education program has to develop a plan and provide services to help mitigate that harm or better facilitate them being able to take advantage of that special education. And this includes all sorts of related services that are speech language pathology, physical therapy, occupational therapy, quite a few different services, audiology, things like that, mobility services. And so That's something that's already a federal sort of requirement in terms of the education agencies to provide for students in public education. One of the differences that came about is that there was an allowance back in the 90s where basically it allowed for Medicaid to reimburse the special education systems for services rendered to Medicaid students. So when they happen to be rendering services that are Medicaid covered services that are part of our Medicaid plan, then it allowed us to reimburse them for the cost to render those services to the students. So that's the structure of the program, and it's been done differently over time and differently from state to state. There have been various different iterations of how this is done. And there is a certain amount of latitude that's been left up to states to kind of set how this happens, as long as it falls within the general sort of regulatory guidance.
And Matt, I'm just going to add too, I think if folks remember a couple of years ago, there were a couple of bills that basically directed Medicaid, let's see who else, the State Board of Education, I'm trying to think who else was involved. Division of Substance Abuse and Mental Health have been involved. I mean, there have been a number of entities involved to study and make recommendations regarding how to really expand the use of really Medicaid reimbursements for services provided in the schools. So this has traditionally been the school involvement that we have had as the school-based skills development program. And a number of these things that we're doing were recommendations that we've been talking about even before that report, but were also reflected in that report. So, you know, as Matt indicated, taking, I guess, loosening some of the eligibility requirements to allow school districts to get reimbursement on more of their children. We used to have, you know, a certain number of minutes in a day that the child had to be involved in the program. We removed that limitation because a lot of states didn't impose that kind of limitation, and frankly, everyone had to rack their brains to figure out where that limitation actually even came from way back when. So this will essentially provide more funding to the schools to allow them really to provide more services to these kids. And then separate and apart from the school-based skills development program is that whole discussion about providing services, whether they be physical health or behavioral health services, to any Medicaid eligible child in a school setting, regardless of whether or not they have an individual education plan or not. So that's a different topic from this school-based skills development program.
Yeah, that's an important distinction. The context in which this program comes into play is tied to students that have an individualized education plan. So as I was saying, we had a payment methodology that was out of step with the current process, and it seemed like it had the potential to leave some money on the table for the districts. And so it made sense to us as we were changing this to move in the direction to more closely align with CMS's current guidance on how this is done to help minimize our liability there. And also it's the way by which we can maximize the reimbursement to the districts, right? So that's the direction for that first bullet. That's the main reason why we're doing it. In addition to that, and kind of in tandem with that, we're transitioning from our older time study methodology, which we used, to a random moment time study methodology, which is again kind of CMS's recommended gold standard in terms of how that should be done. If we could move down, Sharon, to the last one. All right, so in order to help facilitate this change, the Department of Health is contracted with Public Consulting Group, or PCG, to help us transition through that. They will administer the random moment time study and the cost-based reimbursement process and help us navigate that transition. We came in contact with Public Consulting Group through an RFP process through full procurement, and they were the awarded party, and thankfully they bring with them expertise across the country around random moment time studies, in particular within the school-based context, and have done all of this work as far as the cost-based reimbursement model that we're moving to with other states across the country. So they bring a wealth of experience in how to do this and have worked with other states as they have made similar transitions. So the focus that we're in right now, the main drive right now is training the school districts and their staff and onboarding the districts and staff into the PCG system. Basically, we start our time studies as of October 1st, and so we're going through a lot of training, a lot of onboarding, getting people ready and transition from the older process to the newer process. And that includes for time studies, but then also making refinements in terms of our cost reporting process and how those things will come in to implement our cost settlement for our cost-based payment. The idea with the cost-based payment is we'll do an assessment of their cost to project what their cost should be or would be in a year, and then after the conclusion of the year, we do a cost settlement to evaluate what their actual costs were, and if their actual costs were more than what we had anticipated, then we would pay them to make them whole. If their costs were lower than what we anticipated and paid them ahead of time, then they would have to pay back just to get to the maximum allowable reimbursement for that cost. We're also working actively right now and in concert with PCG to update any associated manuals, SOPs, state plan to go along with all of these changes. So those are kind of the broad strokes, but there are a lot of moving parts associated with that. Jesse, again, thanks for giving me the context of how much context I needed to give. I wasn't totally sure. Didn't want to take anybody on a ride that didn't need to go on. But any questions that anybody has about this or any of these details?
This is really helpful. Thank you, Matt, for that. And yeah, sorry to put you on the spot with that additional context. I just think this is such a huge part of, or this is an incredibly important part of the Medicaid program overall. And I think it's good to always kind of remember what this relationship is. On that last bullet point, I know that the issue of allowing kids without IEPs to draw down Medicaid funds is a separate one, but does that require any state plan changes, and could that be folded into? It does not. Okay.
No, it doesn't. And in fact, I think we reflected that in our report. I mean, any Medicaid enrolled provider can provide a service for a Medicaid eligible child in a school setting. It's just a different setting where the service is provided. And frankly, most Medicaid children are enrolled in a prepaid mental health plan, and in many of the schools, it's actually the prepaid mental health plans of the local mental health center that's in the school providing those services. So there's that. And if there was a clinic in the schools, I mean, so there are a few that have, those services on site and they're Medicaid enrolled, they can bill us like any other provider. There really isn't anything special necessarily that the schools need to do for that other than comply with the overall Medicaid requirements. I should say the providers that are providing the services in the schools need to comply with those requirements. So yeah, that would not require anything more.
Yeah. Okay, great. And I know we've talked about that. I think in other states this was a hang up for some schools, but that we don't have this here is a good thing. It's a matter of just districts, being aware that this is an option and moving forward. So,
agreed.
But Matt, thank you. This is really great, and it's exciting to see these changes move forward. And I think those are really important steps for schools. So, thank you.
Yeah, thank you for the time.
Any other questions? Great. Okay. Emma, I think I know we are a little behind, but I think we actually are doing okay in the grants time. So we had budgeted, I think, for a shorter meeting, but recognize that these are important conversations. So you can take it away with the consolidation report.
Yeah, thank you. And those that are on the call, if there's others who are participating in this process, feel free to chime in. But I think where we're at right now in terms of the consolidation process, and we've talked before about the work groups that we've had or that we have, and how we are now going into the second phase of this process, and really focusing on the details now that we need to gather to put together the report that's required under HB 365 that is due on December 1st. So literally we have groups working right now on gathering information regarding all of the detail of personnel and positions that will be impacted by this consolidation. We're gathering information on all of the statutes that potentially will need to be modified, all the rules that will need to be modified, state plan amendments that potentially will be need to be modified, all of the grants and contracts, and all of those types of things that we need to identify what is the scope and what will need to be changed. And you know, some of those changes will be relatively easy changes that will occur in the upcoming session as the organization of the new department gets more and more solidified. But that's really what we're doing right now is gathering that information and then identifying additional questions and additional issues that will need to be reflected in this report. So that's the main activity that's going on. In addition, some of our folks, particularly I forgot what they're called, the EDO and Executive Infrastructure Group, essentially, have been working on what the finance structure looks like for this new department. And I realize, again, that's really in the weeds, but when you consider we're taking two of the largest departments in state government and trying to bring together a finance structure for those two departments, that is taking a lot of work in terms of making sure that as we do that this process does not cost the state more money necessarily, because we've got a lot of federal partners involved and we have federal cost allocation plans that will need to be modified to reflect this new organization. So that has also been a major focus. And then how the state budget for this new department will look in terms of what kind of line items, how many line items are we going to have for this new department. I think I heard that today that bringing together health and human services, this doesn't sound like a lot, but are 19 appropriation line items, which is pretty significant. And I think there's a desire to try to streamline that to give the department some more flexibility. So some work is being done on that issue with state finance, Governor's Office of Planning and Budget, and the Legislative Fiscal Analyst's Office to come to a place where both the executive branch and the legislative branch feel comfortable. And then there's still questions about what do the boxes on the org chart really mean. And I think those are questions that are, we're not only getting from our external partners and stakeholders, but internally from staff too. And so we're going to be further defining what those boxes mean. So I think the chart that was shared publicly had some, organizational entities defined as division, office, program. And as we looked back at that again, we said, we need to better define what those mean, and maybe some of those need to be reevaluated in terms of what they are, because that is going to drive reporting relationships within the organization and who people will need to deal with who are outside of the organization, who, everyone wants to know, who do I go to share my concerns and interests and to get my business done. And so we are going to be spending some more focused time better defining that so that we can share that both internally and externally. So those are really the major things that are going on. There's a lot of detailed work going on right now towards that report. So any questions on that? And there is no spare time. I was going to joke and say we do it in our spare time, but that is our spare time. So there's a lot going on because we're trying to deal with, all the other issues that we normally deal with as well. So, all right. So that's the update on consolidation. And
have you heard anything? I mean, and I do just want to echo the time that this has taken and the amount of other things that you all have to deal with. So I just continue to express frustration on your behalf that that this is taking, that, you know, that maybe this is going somewhere good, but also it's a lot of time. And so thank you all for all the work that you've been committing to these conversations. But for the childcare, do you have any updates on where childcare is going to land and if Medicaid will be part of the sort of reconfigured childcare?
Well,
early care?
I think where we're at this point is that we had a list from that committee, a number of different proposals. I think there were about 4 that they were sharing with the larger steering committee. I know that they were going to report some of this out to the, I'm gonna lose these terms, the Early Education, Childhood Education Commission, I guess. And so, of course, that group will need to weigh in on this. I think the governor's office is going to have to weigh in on this. So no decisions have been made. And when you say, will Medicaid be a part? I mean, we are a part as a funding source. So I don't know that what our role would necessarily have an impact on the organization of early childhood programs, but because, I mean, we can participate and help fund some of those no matter where those programs are located. But no final decisions have been made on any sort of organization. And it's just amazing to me how broad, how many programs are involved in early childhood education and well-being, and how many different ways you could put things in different columns, you know. So yeah, sorry, I wish I had more of an update, but right now it's still all in flux. So.
No, that's helpful. I think as an advocate, I think I would just advocate for you all, for Medicaid to, I mean, you're integrated in all of these programs, and so to be, maybe have a more formal seat or role or whatever it is, and that whatever entity gets developed, that you have a sort of a role in that, because I think I think that's very important. So,
yeah, good point. So the other thing I would just mention about all this process, and I know folks have said, why are we doing this now? You know, when so many other things are going on, and I don't know that there's ever a good time to do something that is this significant. But I will say the benefit that has come out of this is that it certainly has. I think I've seen better communication between all of the programs in both departments than I've seen in a lot of years, and it's really, I think it's caused people to really look more deeply at some of the interactions between the programs and some of the partnerships. And if nothing else, I mean, I think this has been a positive thing to kind of force that communication, because I think everyone believes that we're communicating and we're collaborating and working together. But everyone's also really busy. But this experience has really forced us to take a deeper look. And I mean, if nothing else, I think that has been a positive outcome out of all of this work that we're going through. So we'll see how this all turns out. So, all right, I'm going to move on. Unless there are other questions about consolidation, I'll just move on to some of the other directors' reports. And I know that there has been interest. Oh, I'm sorry. Was someone asking a question? Maybe not.
No, I was saying that sounds good. No.
Okay. So I'll move on to the focus group reports that we basically commissioned in anticipation of the consolidation effort. And one of the goals of the consolidation effort is to improve the customer experience and to improve our customer service as a state to the public. And a big piece of that is the Medicaid experience, and we wanted to find out, from members what their views were of Medicaid, not only in terms of the eligibility process, but also their experience in terms of the benefit that they receive, and just a number of different issues. So we did contract with Lighthouse. Let's see. And they are a Lighthouse Research, and they conducted a number of focus groups on behalf of the Medicaid program. And the focus groups were, I believe there were 13, and Colby, I believe you're on the phone, so if I get something wrong, please jump in. And we wanted to make sure that we had focus groups that address folks in the urban area, in the rural area. We had Spanish-speaking focus groups as well. And we also wanted to break them out into, different demographics. So we had groups that focused on adults, both adults without children and parents. They were just adults. And then a second group that were parents, including pregnant women. A third group involving individuals with disabilities, and then individuals who are seniors. And again, trying to break those out by urban and rural and Spanish speaking, just to get some feedback on the program. And I think generally, I'm not sure that there was a lot new that we hadn't heard before, but as I say that, there were some things that I think normally we don't hear that we were able to get out of these reports. So, we asked them about the eligibility process, and generally there were the feedback, and I'll just read from the report itself from the executive summary. That there were some improvements identified that DWS could make, particularly to their website, which I think that's always helpful to get feedback on these kinds of tools that we use to interact with the public. Some folks felt it wasn't very user-friendly, that we got feedback that it was not very usable in a mobile format, which a lot of websites aren't, and so I thought that was some good feedback. There was a feedback, we heard a little bit of feedback today on imaging and some of the concerns about the imaging process and uploading documents. That came out in the survey as well. Folks felt that the chat feature was not very useful on the DWS website. And there were just some other, like maybe technical things, like that it didn't allow users to go back pages. And a fair amount of feedback from Spanish-speaking members that they felt like in a number of ways, not only on the website, but some other communication, that the Spanish to English translation was not very accurate or was not very understandable. And so, that I think is good feedback. The application process as a whole, again, nothing new that we haven't heard before, that sometimes the process is discouraging, that it's not intuitive to people where to find how to apply for Medicaid on the DWS website, that the application is confusing. I know that, our staff in DWS over the years have tried to make it as streamlined as you can, considering it's an application for multiple programs, but that does tend to be intimidating. We got a fair amount of feedback about the asset limit. So if you recall, there is an asset limit for some of our programs by design, but some feedback about concerns about exceeding the asset limit. And there are still some concerns on the part of our Spanish-speaking members about submitting personal information, I think, just generally to government agencies. So feedback to that extent. A lot of feedback on telephone wait times, that they would like, for the most part, individuals would prefer to have designated caseworkers. I think some of the other feedback that we received on DWS is no different than any organization that would get feedback, which is some people are helpful, some people are not, some people are knowledgeable, some are not. We got some feedback, again, on my case. Largely the concern was, concerns about uploading documents and having to upload documents multiple times and then not really being sure if DWS still really got the document or not. So I think a lot of that information, I think we've heard in other settings, and I think we need to take it to heart and work hand in hand with DWS to try to resolve and address some of these issues. At the same time, we got feedback on Medicaid coverage and benefits. So I think generally the feedback that was received is that people feel that Medicaid's helpful, that Medicaid provides access to care. However, at the same token, we got feedback saying that sometimes it was difficult for people to understand what their coverage and what their benefits are. And that maybe because of the lack of understanding of that sometimes they were hesitant to get medical care. Concerns that providers are limited and difficult to see. I don't really think we have a limited network of providers, but I think just generally we have a shortage of providers. And so, you know, sometimes I think it's hard to get into a provider generally. You know, there was feedback that they felt like Medicaid, and I'm assuming this is coming from folks who are in populations that don't receive these benefits right now, but that Medicaid should provide more benefits, and especially dental and vision care. So, you know, as you know, for our adult Medicaid population or adult expansion population, they don't receive dental, and a lot of our folks receive minimal vision coverage, and so certainly some feedback on that. We also got feedback on behavioral health services that members seem to be somewhat unaware of behavioral health, of the behavioral health benefit, and felt that maybe access to behavioral health services was somewhat limited. And again, I don't know that that's really new feedback, but certainly confirms that we still have to work to try to address that issue. So I think just generally, you know, the reports go on to give some actual quotes in all these different areas. Yeah, I think that's probably basically the summary of the feedback that we received. We also asked for a survey of individuals or a focus group of individuals who were uninsured, thinking that we were going to get more information on why people who are uninsured are not seeking Medicaid, if maybe they had been on Medicaid and then, you know, got caught up in that, you know, getting kicked off the program and not knowing how to get back on the program. But it seemed like the majority of the folks in the uninsured survey really were focused more on discussions about commercial coverage, and few of them had some interaction with Medicaid, but not a lot. But some I do think they felt like there was some what's the word I'm thinking of right now? That being on Medicaid was a little bit embarrassing. It was it was something that they wouldn't necessarily seek, even when they possibly could qualify. They viewed it as being a program for someone else, not necessarily for them. And they expressed still a lot of confusion between what Medicare and Medicaid is, and we run into that all the time. So I'm not sure that focus group was as helpful as the other one, but it still gave us some indication of, I think, what the general public feels about Medicaid and just generally some of the confusion that they have about the program. So I'll stop there and see. Colby, I don't know if you're on, if you want to add anything to what I've said.
No, I think you covered it very well and thoroughly. And I agree that the second group, the unenrolled group, didn't garner as much information as we had hoped, but I think there was a lot of really great feedback from the enrolled members and how we can improve our processes and communication.
Yeah, so any questions? I mean, we can post those on our website. I believe, Sharon, did you share the actual focus group reports with the MAC?
No, I have not shared that.
Okay. I mean, they are public documents. We could post that information on our website and give folks the link if they want to basically take a look at more details in those reports. And again, the rest of the report really just cites some more specific quotes from some of the focus group members, and then talks more about the methodology that was used. And I believe the questions that were asked and that type of thing are in the reports as well.
I have a question.
Yeah.
Oh, sorry. Thank you for sharing. And yes, I'd love to see a copy of that as well. So a lot of these, like you said, this wasn't new feedback. And so I'm just curious, is this also something that's going to be tracked on an Excel sheet so that we can track what changes happen? Because this is, it's always nice to hear that a lot of us are experiencing the same thing, I guess, in a way it's validating, but at the same time, it's not new. So I'm just curious, like, what is the next step?
Yeah, I mean, I think we could certainly do that. I mean, we could certainly take these items and, track them on a spreadsheet and develop some plans around these items. I was kind of surprised at some of the feedback that we got, even specifically around the benefit and the lack of knowledge about the benefit. And my thought was, okay, how do we communicate that in a better way to members? So we can certainly do that, Stephanie. I think that would be an appropriate thing to do. The other thing too is that one of the new work groups that's been created as part of the consolidation is a work group to address consumer experience. Trying to, I think Tracy has two concerns. One is she wants to make sure that the public has a good experience with the Department of Health and Human Services, but also that we need to make sure that people know how to navigate the system. And part of that, as we've been having our discussions, we realized that workforce services is a big part of that as well. So they have been invited to participate as part of this consumer engagement work group as well. So I think we can track these items and start working towards a plan to address them, and certainly report back to this group periodically too about how that's going, and share the Google Sheet or however we're going to do that.
Thank you. And are consumers going to be on that work group?
They're not right now the way it's configured, but the intent of all these work groups is to reach out to stakeholders. So I'm hoping, and we can certainly make this recommendation, that this work group will actually reach out to and involve some consumers to get their feedback. I think that would be helpful.
Yeah, I agree. And then lastly, sorry, I'll be really fast, but I just want to make sure I understood. So did you say that the group of people that were not enrolled, it seemed like there was qualitative feedback that added to something I think a lot of us believe is real, which is like the stigma of poverty and poverty programs and keeping people away from the programs?
Yes, thank you. I was trying to search for that word. Yes, that there was some stigma about being on Medicaid. That was some of the feedback from the uninsured group.
Okay. Yeah, that is helpful to have that in writing as well. Is that who would be responsible for trying to address that? Is that something the governor's office would be? I mean, like, there could be public campaigns of like there's things we can do to try to decrease that in some ways, to try to lessen the stigma of of these programs and make them more like normalized and accepted. Is that something that the governor's office is interested in? Do you guys know?
I don't know. I mean, we have not had that discussion with the governor's office. I mean, I think that's consistent with, ACA in general, right? I mean, that the whole idea is that these are just different ways of getting coverage, and I think the concept of the Affordable Care Act was to try to take some of that stigma away, and just make it pretty seamless between Medicaid and the marketplace, and but I'm not sure that has successfully really taken here or any place else for that matter. So, but I'm not aware right now. I think right now the governor's office probably has so much on their hands with everything going on. I don't know that this is on their radar at this point.
Okay. Well, thank you for sharing all of that.
You hear me?
Yes.
Hi, this is Luis Rios from Taker, Utah, the Utah Health Policy Project. And I mean, on that subject, I guess my topic is, my question is, we see a lot of people, right? That's what we do. We help people. So is there anything that you guys think that us as the sisters could do to help with the stigma? I mean, like, I don't know if there's anything else that we could do, like any type of messaging or words that we could use to help individuals do that. Because, I mean, I don't hear it a lot, but once in a while, especially I guess with the expansion of Medicaid last year and having individuals be moving from the marketplace back into, Medicaid or into Medicaid, I heard that a couple of times, a handful of individuals that expressed kind of like not wanting to go to Medicaid because, statement. So I just kind of wonder if you guys have if anybody here has any way, like any wording, anything we can use to help with that, it would be welcome for our organization to be able to help with that.
Yeah, and that may be something that actually we should talk about. I don't know that we have any specific wording other than just to emphasize that, we're just, we want to see people have healthcare coverage and focus more on the benefits of healthcare coverage, not necessarily what program you're getting it from. Historically, we used to hear that quite a bit from CHIP families, that in their minds, there was something different between being on CHIP and being on Medicaid. And, for them, being on CHIP was not the same as being on Medicaid. And so, I don't know that we have any magic words other than emphasizing the benefit of having healthcare and sort of staying away from, it's not a stigma. This is what these programs are intended for, and having healthcare is a good thing, So I don't know. Perhaps others have some recommendations, or maybe that's something that just we could take offline and try to work through.
Well, Emma, I guess a question. I was going to say, I think, Luis, thank you for the question. And I think, when you're interacting with people, a lot of that stigma, I think it's part of how we overcome that stigma. I was thinking about the outreach funding as also a potential way to explore some of these issues. And I'm wondering if you have an update on that and some efforts to, on the outreach funding from the 2021 session.
Yeah, and I hope Colby's still on the phone. So we are moving forward to hire the FTE who's going to help on this. And I know Colby was going to be doing some research on, part of our plan was to engage, again, another, communications or marketing company to help us do a lot of this work. And so, Colby, I don't know if you have any update on whether or not we've determined if there are some that are on state contract that we can engage, or if we're going to have to do an RFP.
Yes. So statewide contract is actually not ready to go until mid-September. They've been changing their contracts, and they don't have any current available contracts. They are expecting them to be in place by mid-September. So instead of issuing our own RFP and going through the hoops there, which would take us nearly into January in order to get contract in place, we're just going to wait for this mid-September mark to explore, hiring a marketing firm and exploring our options of what we can do with spending this funding we've been giving to maximize our outreach efforts.
Okay. All right. Do you want me to move on? Oh, go ahead.
Can I ask one more question, actually? And then I saw, two more questions on the Lighthouse research. One, with all the recommendations that came out and the funding from the American Rescue Plan, how can we, that seems like it seems like the perfect opportunity. There's all these funds available, there's a lot of funding available and a lot could be directed to make one-time changes to, computer systems or interfaces, or, the website. How can we help that move forward and use, is that an opportunity, and how can we help that to help move some of these recommendations forward?
honestly, we haven't thought of ARPA funding as being, one of the ways of doing this, but we could certainly look into this or look into that. I mean, when we got the appropriation on that bill for the outreach, one of the things that we put in the plan that went into our fiscal note was using some of that funding to improve websites. And so we hope to use some of that funding to do that. And we also, had in mind of potentially using some of that funding and working with workforce services, to say, hey, we've got some money, let's talk about ways that maybe we could address some of these issues. But we could talk about the ARPA funds as well. I mean, there's some very specific purposes for those funds, but perhaps, I think folks are broadly interpreting those purposes, and we could maybe have some discussion about that and see if that's a possibility.
That'd be great. And then just one question I wanted to flag, Sarah's question in the chat around the question about Medicaid benefits, and is there a breakdown of Hispanic recipient feedback?
Let's see. I don't think it's broken out specifically. Colby, is that correct? I don't have it in front of me right now, but I mean, there's some of the comments that were made, the specific quotes, they've identified like which focus group and whether or not it was a Spanish speaking focus group or not. So you can get some idea there. But there really isn't anything like, percentages of this many percent of each focus group, shared the same opinion that I recall. And Colby, I don't know if Lighthouse could even break it out that way.
I can check with them. We didn't request for specific quantitative data. It was more just qualitative and anecdotal experiences. And so that's really what they captured in the report. I know Sharon is actually going to be sending that out soon, so you can look through. And then if you have additional questions on, what more information would be helpful, we can certainly go back to Lighthouse and see if that's something they have access to.
Okay, thank you.
Thanks.
Okay, and let's see. Considering we didn't think we were going to fill the full 2 hours, I'm going to quickly, if that's okay, Jesse, go through the rest of the updates.
Yeah.
So, so I will just address policies, rules, and SPAs right now. In terms of state plan amendments, we don't have anything new that we're working on in terms of state plan amendments. We're still going back and forth with CMS on some of the ones that we've submitted that you're aware of from before, such as adding the changes related to physician assistants and what they can and cannot do based on Senate Bill 27 and 28 that were passed in the last session. We're still going back and forth with CMS on getting approval for us to cover the crisis line for Medicaid recipients and the rate for the crisis line. That has not been approved yet. We're still exchanging phone calls and questions with CMS on that. In terms of rules, again, not a lot of new rules that have been submitted, except for one that we are submitting, and that is we're updating our rule regarding client review and education and the restriction program. And what we're doing is the rule that you'll see, and it's just barely coming through our process being reviewed, and we can share it with this group, is just capturing how the restriction program works and has worked, capturing that in rulemaking so that it's I guess more transparent in terms of how the program works, and particularly how the program works between the state and our managed care plans, our ACOs. There is a lot of interaction between the ACOs and the state on any restriction client that is enrolled in an ACO. And so just outlining those relationships and those expectations, how often an individual who is on restriction, how often their utilization needs to be reviewed, what the criteria is for putting a person on restriction, what the criteria is for taking someone off. because we're just as concerned about making sure that the person should be off of restriction if they have changed their behavior and there's no reason for them to be on the restriction program, making sure that it's clear when that should happen as well. So we're working through that. In terms of policies, I think we've covered some of these before. Again, with everything else going on, we're really just focused on implementing what came out of the session and not necessarily taking on any new policies. One of the things, though, that we're actively working on is HB 178, which is the Pharmacy Practice Act modifications. And again, if you recall, this is the bill that will actually allow pharmacists to prescribe certain drugs. This is a fairly significant change, although I know our plans are working on this, and some of them are already doing this, but actually allowing a pharmacist, not a pharmacy, but a pharmacist to be a prescriber in the Medicaid system. And they will have the ability to basically prescribe post-exposure HIV and pre-exposure HIV, prophylaxis, basically some contraceptives, birth control pills, smoking cessation drugs, and naloxone. And so we're working through all of that process with our department and again, in our systems and so on and so forth to be able to make that happen. And I believe that takes effect January 1st of 2022. We're looking at specifically a code that would be used in a primary care setting for pediatric depression screening. So we're looking to open that code up. That has been brought to our attention that that's not open, and we think that's a good thing to do. Some of the other things, I guess probably the two most significant things that we're working on is just recently CMS has come up with new guidance on non-emergency medical transportation. So that has not always been, and in many states is not a mandatory program. This new guidance, basically changes were made to the federal law that now requires this to be available for Medicaid recipients, which is fine because we do provide this. The other piece of this, though, is that it's also going to require stricter vetting of non-emergency medical transportation providers, including their drivers, and including drivers where they may be Lyft or Uber drivers. A lot of states have entered into agreements either through a non-emergency medical transportation contractor who then has subcontracted with Uber or Lyft or other rideshare programs, or they've attempted to contract directly with some of these rideshare companies, and they will all be subject to basically being vetted against the federal databases and several different requirements that I think are good to make sure that our Medicaid members have safe and appropriate transportation, but may also be a little bit of a barrier or discourage some companies from wanting to participate as non-emergency medical transportation providers in our system. So we'll be working on that. And then the other big one that CMS just issued last Friday is new guidance on the unwinding of the maintenance of effort. So what they are saying now is that they're going to allow states 12 months after the month that the PHE expires to basically unwind the maintenance of effort. But at the same token, they're also saying that with that, that means that states will have to conduct a renewal on every case. And go through an eligibility determination on every case during that 12-month period. And there's still some question as to whether or not the enhanced funding will still be there. So we could have a situation where states are maintaining individuals an expanded caseload and not getting the benefit of the enhanced federal match, which is going to be a financial consideration for all states as this sort of rolls out. So again, trying to work through what does that mean, and we have not had any time yet since it just came out on Friday to sit down with DWS and start talking through what that means for us together. So those are the things we're going to be working on in the next little bit. So we can keep this group updated as we work through that.
Thank you,
And
Emma.
lots of other things, but so, okay. Any questions on those?
No, that was a great overview. I think more. Oh, actually, Jennifer has her hand raised.
I actually have a question this time. I saw the letter from CMS regarding the community engagement requirement.
Yes.
Does the state have to appeal that based on SB 96? I tried to go back through the wording and I totally got lost. I just wondered what the status of that was.
Oh, yes, I'm sorry. That's a big thing. And I just totally spaced that. So yes, we did get our letter. Basically, we were notified by CMS that they are going to withdraw their approval of our community engagement requirement in our 1115 waiver. So basically our work requirement, although as you know, it's been suspended since the public health emergency was declared anyhow. So we have not been actively doing anything with that requirement. So we are working through the process right now because this takes effect in 30 days, which essentially means that we have no authority after 30 days to operate that requirement. I don't believe that there is a requirement that we appeal that decision. There are some discussions going on about whether or not we should, and when I say discussions, I mean, we've asked the governor's office, we have notified all legislators of this action, what CMS has done. We're not hearing a lot of feedback yet. And I think that's largely either because everyone kind of expected this, or also I think everyone has a lot on their plate. And what we've also offered as an alternative is, we can still make our members aware of the resources that are available out there, which I still think is a good thing to do, is to make them aware of, here's the website, here's how you can do job search, here's some resources. And we've reached out to Workforce Services and said, we'd like to, sit down with you and talk about how can we make that information more accessible to our members. And so we'll be working on that as well. But so far, we have not been instructed that we have to appeal it. And we frankly did reach out to our contracted counsel. We have most states contract with a firm out of DC that is a Medicaid expert firm and has been for years, and asked that very question. Have other states appealed, and what's the legal likelihood of success? And because of the way that the Social Security Act is written, the sense is that it would be very difficult to overcome CMS's action on this. So, but we'll stay tuned and see if we get direction to do something or not. But right now, we're taking the approach that we have to unwind the community engagement pieces out of policy and out of rule and out of our system changes. And so that's what we're planning on doing right now.
Thank you.
Yep. And thanks for reminding me. That was a big one. I just totally forgot.
Thanks for that. That's a great, more to come, I guess, on that, but please keep us posted if things move in a different direction from where they're currently headed, especially. Well, with that, glad we had a short meeting planned. It's past the hour. Are there any other final questions or things to flag? And we'll be sending out, sounds like a lot of stuff, follow-up. So please, check your inboxes for the reports, also for the notices spreadsheet and a variety of other things. So a lot of follow-up information, but any other final questions before we close the meeting? All right. Well, thank you so much. Thank you so much, everybody. And we'll see you in September virtually. And the meeting is adjourned. Thanks.
Thank you.
Bye, everybody.